Hi, this is Dr. Ralph Blakey, supervising physician for Bellingham EMS, and I wanted to take a minute to talk about pediatric viral respiratory infections, because if you recall from last year, it was about this time of year when we became overwhelmed with RSV in our community. And if you remember last year, again about this time of year, this red line represents the spike we were seeing last year in RSV, whereas typically it is more of a plateau. And that seems to be the case this year again, and it appears to be heading our way. If you've been reading the news, you have read about the RSV cases that are flooding other hospitals, and it is anticipated that we'll be seeing this shortly. So in anticipation of this, I wanted to go over this quick slide presentation, and I'm just going to begin with a few slides on pathogenesis. As you know, the respiratory viruses are generally spread through inhaling the virus, which will then be contained in the respiratory tract, and this mucus plays a role in trapping that virus, and the cilia on the epithelial cells help transport it back up and out. But if the virus invades into the cells itself, it can cause damage to the cells and can cause an inflammatory reaction, which leads to a lot of the symptoms that we manifest. And as more of the cells die and you can't produce the mucus, and you're getting more of a inflammatory viremic response, you have worsening symptoms as it progresses. I'm going to talk about the different specific viruses and where they infect, and I'm going to start in the upper respiratory tract, and I'm going to talk about the common cold, most commonly caused by rhinovirus, and it affects just the nasal epithelium. And if you're to look in the nose at the turbinates, you would see this inflammatory response. And we know that it takes 2 to 3 days for you to develop symptoms, and you'll be sick for a week. But fever and systemic symptoms are uncommon in rhinovirus. The viruses that can cause a sore throat or even laryngitis are typically adenovirus and parainfluenza virus. And adenovirus is characteristic where you can see these exudates on the tonsils, and often associated with conjunctivitis and sometimes otitis. When we get down into the lower respiratory tract, the upper airway in the lower respiratory tract to get affected is typically causes the symptoms of croup, or as we call it, laryngotracheal bronchitis, because of the area that affects. This is most commonly caused by parainfluenza virus. You don't need an x-ray to diagnose this, but if we do get an x-ray, we can see a very characteristic steeple sign from the swelling and narrowing of that upper airway in croup. Croup has a very characteristic cough, described as a barky cough, and is related to where it affects the airway. I'm going to spend the rest of the time talking about viruses in the lower respiratory tract, in particular where RSV affects the respiratory tract. RSV is the most common cause of bronchiolitis, which is the major cause of respiratory disease in kids, particularly less than 2 years old, and the #1 cause of hospitalization in the young age group. Again, it's bronchiolitis typically caused by RSV, and the season is from the fall to the early spring. And when we're talking about bronchiolitis, we're talking about the virus that gets into the bronchioles, which are the smallest airway tubes before it feeds into the alveoli. And this causes inflammation and swelling and mucus production, which decreases the airway and the space for air to travel, which leads to a lot of the symptoms that we see in bronchiolitis. And those symptoms are runny nose, and it is quite characteristic of RSV is that they'll have profuse watery rhinorrhea, very characteristic of RSV. And you'll see the rapid breathing, the tachypnea, and you'll see the retractions and labored breathing. It's important to recognize those who are at increased risk from getting sick with bronchiolitis, particularly the ones who are born premature, and you should always ask if they were born 36 weeks or less and if they were low birth weight. The younger kids are also more at risk because their airways are smaller and can't tolerate the swelling that a larger airway would be able to tolerate. And again, it's something that can be diagnosed just based on symptoms and exams and doesn't require any laboratory or x-ray testing. When you're taking care of these kids, it's important to find out how long they've been sick. They will continue to get sicker until day 3 to 5 is when they would typically be the most sick, and then they'll have a prolonged recovery. So if you're seeing a sick kid who's only been sick for a day or two, odds are they're going to get sicker before they're going to get better. But if you're seeing them in this 3 to 5 day window, they may be just about to get over the hump. And on your exam, you want to look for these retractions that you'll see, the intercostal retractions as the skin gets sucked up in between the ribs, and you'll see subcostal retractions where the skin gets sucked up underneath the rib cage. And you may appreciate some nasal flaring as they inhale and flare their nares. And these are just some examples of RSV. So the treatment of bronchiolitis is simply supportive care. One of the most important things is just to make sure that they're adequately hydrated. If they are unable to feed because they're working so hard to breathe and getting dehydrated, that's a reason to be admitted to the hospital is for hydration. So doing everything you can to keep that kid hydrated is important. Aggressive nasal suctioning that we'll talk a little bit more about is really a mainstay of treatment for this. And for the percentage of kids who still are unable to maintain their oxygenation, that's another reason for admission to the hospital. So to go over our protocol, which is for croup, RSV, and epiglottitis, I won't be talking about epiglottitis in this talk, but it is the BLS interventions include the nasal suctioning and oxygen as necessary. The ALS protocol includes albuterol, nebulized epinephrine, and IM epinephrine. I would suggest that nebulized epinephrine in the Stridor's kid would be the first thing you would try. In more severe cases, you can consider IM epinephrine, but just remember when you have a croupy kid, the more agitated you get them, the more respiratory distress they're going to have. This is the scoring tool that we use in the hospital to help us decide how to treat and who needs to come in and who can be allowed to go home. And it's based on their age and their accessory muscle use, what their lung sounds are, how alert they are, and how dyspneic they are. And we use a scoring system to determine what our treatment strategy is going to be. We allow them to be discharged home if they can maintain an oxygen saturation of greater than 90% when awake or 88% when sleeping. Again, they're able to maintain their hydration. It appears that they're able to maintain their work of breathing without fatiguing. They've got somebody reliable who can take care of them, somebody who's able to follow up with them to ensure that they're improving. And for the kids who use albuterol, make sure they've got albuterol at home that they can use. As I said, the mainstay of treatment is nasal suction. One of the tools that parents have found to be most useful is the nose Frida. If they come to the hospital, we use this olive tip, which is hooked to suction, and similarly, we aspirate the nares using this. So I hope that was helpful. This is Dr. Ralph Weike, supervising physician for Bellingham EMS, and I appreciate the good work that you folks do.